Hello, good evening, everyone, and welcome to our Facebook Live session. My name is Mark, and I will be the host for tonight's live session. 365 Live is a platform where we educate the public on cancer and encourage a cancer prevention lifestyle. Whenever you see this logo, you'll know that 365 Cancer Prevention Society is currently having a live broadcast. This talk is specially brought to you by 365 Cancer Prevention Society. 365 Cancer Prevention Society was founded in 2003 as a social service agency with IPC status, and we are a full-fledged member of the NCSS. The society's mission is to serve the community through holistic cancer prevention measures. This is accomplished through health and nutrition education, promotion of healthy lifestyle, and our lymphatic detox exercises. We also provide practical and emotional support and care for our members and their family members in their battle against cancer through our residential and hospital visitation, counseling, nutrition consultation, and wellness services. So please like, share, and comment on all of our social media pages for the latest updates on our events and activities. We would also like to take this time to thank our co-organizer, OncoCare Cancer Centre, for partnering with us to make tonight's talk possible. You may follow their social media for more updates. Before we begin tonight's talk, I'd like to share an ongoing screening campaign by 365 Cancer Prevention Society. Since September, we have launched Stay Clear of Gastric Cancer, a free gastric cancer screening for individuals who are 40 years old and above and holds a valid blue or orange CHAS card. If you fit the criteria, you may sign up for this free screening through the sign up link we have pinned in the Facebook comments. So do click on that link to register. Once again, please share this screening with any of your friends and family members who may qualify. Remember, early detection saves lives. So before we begin tonight's talk, I'd like to share an ongoing screening campaign by 365 Cancer Prevention Society. My First Colonoscopy is a free colorectal cancer screening jointly organized by 365 CPS and Icon Cancer Centre for individuals who are 45 to 70 years old with a valid blue or orange CHAS card. So if you fit the criteria, you may sign up for this free screening through the sign up link, which we have pinned down in the Facebook comments. Yeah, so feel free to share this with your friends and your family members. Remember that early detection of cancer means earlier treatment, and that will save lives. So before we start our talk today, kindly note that all information shared at this event by the speaker and 365 Cancer Prevention Society are for general information only and subjected to changes. Do consult your doctor for personalized and detailed medical advices. Due to the nature of this talk, there may be graphic images. Viewer discretion is advised. Before we begin today's talk, I would like to introduce tonight's speaker. Dr. Tan is a palliative medicine doctor who has provided palliative care for more than 20 years in different settings, including primary care, home and inpatient hospice, community hospitals, as well as tertiary hospitals. He now works as senior consultant in palliative medicine at OncoCare Cancer Centre and provides palliative care to patients with both advanced cancer and non-cancer conditions. So without further ado, let us welcome Dr. Tan. Hi, Dr. Tan.
Hello, Mark. Thank you for the kind introduction and thank you for having me on your program.
Okay. No problem. So thank you very much for joining us tonight to share your knowledge with every one of us here. So now let me hand over the time to you, Dr. Tan.
Thank you. So good evening, everybody. Right, I will be talking about this topic on receiving palliative care to live. So maybe I should get the context of this talk right first. So this talk is about the condition where the cancer has become very advanced and despite all kinds of treatment. So suppose if the cancer has become advanced for any one of us, if there is a form of treatment or form of care that can reduce physical symptoms such as pain, improve mood and allay depression, or it can help you maintain your function and your quality of life. And perhaps this kind of care can even prolong your survival. So do you want such care? And if we put this question to many people, most of the people will say yes, they'll probably consider such care. Would you be able to accept this care? And once again, I think most people will say, yeah, they will probably be able to accept this care. So if to both questions we answer affirmatively, then maybe we should consider palliative care. But here, I think some people may really scratch their head and say, well, really? Because this whole idea of palliative care and improving well-being as well as even prolonging life doesn't seem to be very intuitive. Okay, so let us see what we really know about palliative care, what palliative care can do. I will bring up this study first. This study comes from research that was done quite some time ago, about 10 years ago, published in a very famous journal. The study involves about 150 patients, and they were randomly selected to enter into early palliative care together with whatever treatment they are receiving for the cancer, or standard care. Now, a good thing to note is that these are all patients with stage 4 non-small cell lung cancer, so they are quite advanced in the disease. And what we found was that patients assigned to early palliative care seem to have a better quality of life. And this is not new. Many studies have shown that patients who receive palliative care do report a better quality of life. They also found that fewer patients develop depressive symptoms, which is also what we commonly know. You just give me, yeah. Can you see my slides move? I have actually moved. Oh dear. How do we resolve this? Can you see now? No? This is in presentation mode. Can you see now? I'm afraid the slides didn't move with me. Okay, let's try again. So sorry for this thing. Okay. Shall we stop the share for a while?
Hi, Dr. Tan. It's not in presentation mode.
Yeah.
Not sure why. Yeah.
Yeah, I will stop the share and then go into presentation mode.
Okay,
And
sure.
then, but how do I can't.
Maybe you can just share again and try to present.
Okay,
Yeah,
sure.
thank you.
Share screen. How's that? You can see, but you can't see the presentation mode, right?
Yes, I can only see it as slides, but not in presentation
But once
mode.
I
Yeah,
go
so
into
it's a little
presentation
small.
mode, can you see now? Can I move the slides? Can you see
Nothing
the slides?
changes.
Yeah, but I'm
Nothing
actually
changed.
clicking it down.
Oh, I see. Then I
Yeah,
think
we
yeah,
can maybe
okay. If you click like that, it's fine. Yeah.
yeah. So I will just change this mode
Yeah.
to how do I move this away?
Oh yes, this is better. Thank you.
Yeah, this is
You can
better.
continue. Thank you.
Yeah, but this is not presentation mode, so it won't change my graphics, unfortunately. How about now? Also cannot.
Yeah, it's okay. I think this is good.
Is it moving?
If
I'm
you
moving
click
it.
into the next slide, yes.
Can you see it clicking?
Can you click to the next slide, please?
Yeah, I've already clicked the next slide.
Okay. Okay, can.
You're still on the
For
same
now.
page, is it?
It says when the cancer has become advanced. Is it
No,
that slide?
so I've moved already. Somehow it
Oh,
is
then.
not the
Oh,
it's
okay.
not
Now can
followable.
already. I
Now
think it's
can?
lagging. Yes.
No. Now I switch back
Palliative
to the
care.
normal mode. Yeah.
Yes. Yeah.
Okay. Well, I suppose we can't have because there are some with the animations. I think we cannot use the many animations then.
Yeah.
Okay.
And just a gentle reminder to the audience, since we are unable to do presentation mode, maybe y'all can watch in full screen so that y'all can see the slides clearly. Yeah.
Okay.
Thank
How
you.
about okay now? So
Yes.
okay. So right. So I was saying that there's this study that shows that look, people have fewer depression, people have better quality of life, and they also found that amongst the patients who were assigned to early palliative care, fewer receive aggressive end-of-life care. And yet, although fewer people receive aggressive end-of-life care, what was surprising was that they had a longer median survival. And this is the difference was as much as 3 months. So if we look at this survival curve, what we realize is that the red curve is the one that represents those who are assigned to early palliative care. So you note that at each time point there is a gap between the red curve and the blue curve, and basically this side represents how many percent of people are still alive. And you find that those who have early palliative care all tend to survive better, right? And in another study, when they look at 4,000 over patients from a cohort, uh, and with particular attention to 6 populations. So these 6 include people with chronic heart failure, lung cancer, pancreas cancer, colon cancer, breast cancer, and prostate cancer. And what they found was combined, the survival was also 29 days longer. Now, good to note that this study talks about compares people who uh, are enrolled in hospice versus those who are non-hospice patients. Of course, in the United States, once they go into hospice, they would have been excluded from any aggressive form of treatment. So what it does tell us is overall, it seems that going to the hospice doesn't really shorten a person's life. Right. And more specifically, they noted that, there is a very significant difference between people with chronic heart failure. People who are enrolled in hospice tends to seem to live longer, as well as, people who have lung cancer and pancreas cancer, and to a smaller extent, people with colon cancer. So what is the cause of this? So subsequent papers try to clarify what was going on, and they sort of suggested that when you have early palliative care integrated into that treatment, the management of the patient, certain things come into play, like having practices and processes that involves a team. Uh, there is a better decision making. There's education and support, and there are also uh, a few patient level targets. It's not just about managing the disease, but it's managing the physical, psychological, social, cultural, spiritual, and even legal aspects of the condition. And also there's another part, which is caregiver support. And all these things come together to provide that to result in better quality of life, better symptom management, better mood. The patients and families also tend to have a better illness knowledge and understanding. And as a result, they also have better coping behaviors. So they postulated that all these things contribute to better health behaviors, and that results in better survival. No, but to live actually is not just about lifespan, right? Lifespan is just one aspect. I think if we look at many patients, some of them may report that, hey, although they are alive, they feel that life is unlived. And then this could be a sense that they have not lived their life well before the illness, but certainly during the illness, many people feel, look, life has been changed. It's not the same anymore, and they feel that there's one part that seems to be always lacking. And in the more extreme form, people can even experience so-called death before the end of life. And this could be in different aspects. For example, people may experience social death, and that means they have a sense of isolation. They feel that because of the illness, because of what's happening to them, they feel very isolated. People don't understand them, and people move away from them. Or it could be psychological. So they can't seem to get out of the thinking pattern that everything is going to come to an end. They couldn't think of a way to live on. Or it could be emotional, where they feel everything is so bleak. They feel so sad, as if they have already died, and they are grieving, and they couldn't find any way to experience joy. Or it could be a spiritual death. Spiritual death means sometimes even before the person is dead, they feel the loss of faith. They feel that living on is meaningless. So in the palliative care setting, I think this whole idea of living well is important. And in simple terms, we often talk about living well means the ability to do what matters. Okay. Of course, what matters to each person is different, but we consistently observe that when there's a major illness that strikes anybody, perspectives about what matters changes. When people are well, they have a lot of wants. I want to do something. I want to get this thing. I want to achieve certain things in life and stuff like that. But after a significant life event, such as a major illness, then perspectives change. We tend to go into the essence. We get rid of all those things that are basically trivia, and we focus on what really matters in terms of our own happiness and our own sense of peace. Of course, having an illness, advanced illness, presents many obstacles to a full life. A lot of them can be related to the disease, but there are also some that are less so. So, these conditions that become obstacles include things like pain. While cancer pain doesn't happen in everybody, when it happens, sometimes it can be serious enough so that we don't have any predisposition to enjoy life. Or it can be things like weakness, fatigue, anxiety, worries, depression, and even sense of helplessness and meaninglessness. All these are obstacles. I also want to bring up this thing about treatment. Treatment can also get in the way because when we are so focused on getting treatment, particularly if the treatment does not give us the results that we want, and yet it consumes all the resources all the time. And sometimes when we go through all these treatments after treatments that bring little benefit, our opportunity, the time and the resources and the opportunities to live a full life also gets lost. So how do we reclaim our life, right? So I think we need to shift the way, we need a different approach to have a state of mind and body to do what is called living, right? Very often among cancer patients, there's this notion that, we have to keep fighting, but it's not always about fighting. Because this idea of fighting, while it gives us a kind of energy to move on initially, but fighting against something that doesn't work, and you keep fighting and fighting, in fact, generally speaking, in any kind of fighting, there will always be a loser, right? And sometimes nobody wins in a fight. All the energy is used up, all the resources is used up, right? So in the situation of advanced illness, when the disease is very advanced and despite all kinds of treatment, sometimes fighting might not be the best solution, right? What we advise people is, look, you can continue to receive treatment. You can continue to try different methods of helping to deal with the cancer, but don't forget on quality of life, right? Tackle quality of life issue. And how do we do that? We address, as a start, we address things like physical distress, things like pain and other kind of symptoms and breathlessness and so on. And that puts us in a better position to live. We address also emotional, psychosocial distress, spiritual distress, but not to forget practical matters. Now, practical matters are things like what can we eat? Who is going to look after the household? Who's going to do the chores? Sometimes when we are ill, we need that peace of mind, and to have all these things there that's not being addressed, even practical things, and the house is a mess, or relationships are broken and stuff like that. We are not in a really good state to enjoy ourselves, and less to speak about a state to deal with the disease. Now, quality of life, some people may be worried, if I focus so much on quality of life and I'm just having a good time, what about fighting the disease? Will it cause me to die faster? It's like being happy, but you die faster, right? So when we look at this study basically involves about 2,000 over patients with non-small cell lung cancer. And what it shows is that, if we ask people about their so-called quality of life within the first 6 months, so these are early cancer patients, the first 6 months of receiving a lung cancer diagnosis, so quite early on, that can somehow be a bit predictive about what's going to happen later. For people with good quality of life, we find that, hey, they tend to live longer. Okay, of course, this is not a study to talk about what's the mechanism behind this. There are many ways that result in this longer survival. But I suppose the important take home is that for people with better quality of life, generally they survive longer. Okay, so you may ask, then why is it that so many people still avoid palliative care? I think that is related to a number of myths that's going on about palliative care. The first myth is, of course, that palliative care is only for dying people. When we look at how palliative care is formally defined, okay, if we look at the definition from the International Association of Hospice and Palliative Care, it says palliative care is the care of patients with active, progressive, far advanced disease. Okay, so I've talked about this in the context, and it continues, for whom the focus of care is relief and prevention of suffering and the quality of life. So once again, relieving suffering, quality of life. These are the main keywords. Now, the World Health Organization definition is a bit longer. It says palliative care is an approach that improves quality of life of patients and their families facing the problem associated with life-threatening illness through the prevention and relief of suffering, right? By means of early identification and impeccable assessment and the treatment of pain and other problems, physical, psychosocial, and spiritual. Now, don't worry about trying to remember what it says, but notably, be aware that none of these definitions talk about death or dying. So it's not about dying. Palliative care actually is all about living. It's about how we can continue to live well despite the advanced disease, okay, regardless of time. Time is how long we will continue to live. Actually, nobody knows. I can't even tell what's going to happen to me tomorrow, right? But what we can do is that, live well, focus on the now, what we can do now. And as we have said earlier on, sometimes for certain patients on palliative care, they actually live longer. Another myth is the idea that palliative care starts only when there is no further medical treatment. Okay, I think this myth comes about from a very traditional model of care. And in this traditional model of care, people tend to exhaust all the active treatment of the medical condition or the underlying condition. They try to do everything first, and when all options have been exhausted, then they say, okay, now the patient is ready for palliative care. Okay, there are some problems with this kind of model. Firstly, during this phase, the first part when they are treating all the medical conditions, as they progress closer to death, the treatments, all these treatments don't work so well. They cause more side effects, and the patient actually suffers both from the disease and may also suffer from the treatment. Okay, so quality of life tends to be poor until the end. And depending on when they refer to palliative care, if they refer very late, then the opportunity to receive palliative care to live well is much less. So it's not so useful already. The modern model of palliative care, however, looks like this. So upon the diagnosis of a far advanced disease, yes, cancer treatment can proceed. At the same time, we also treat any medical conditions like fractures, bowel obstructions, and infections. But at the same time, we can start palliative care here. Sometimes palliative care at this stage is also known as supportive care. And as you can see, with time, the cancer treatments become less and less effective. And towards the end, the options for cancer treatment, cancer direct treatments become nil. Even at this stage, we can see that we can still continue active medical treatment for the conditions of any complications of the disease and so on. But palliative care becomes more and more important. And towards the end, when all kinds of treatment are not useful, we still have, we can continue palliative care to make sure the person stays comfortable, stays well all the way to the end. Okay, at this stage, some people call this kind of palliative care end of life or hospice care. Now, another myth that is very common is that unlike active cancer treatment, palliative care is passive. It means doing nothing. Yeah. So many people say, oh, go to palliative care means you do nothing and you just wait. Okay, but this is not true because palliative care can also be an emergency kind of care. I think for anybody who is having a lot of suffering, like in an acute pain crisis, we need to relieve the suffering as fast as possible. Okay, this is an emergency because the time that the person has suffered it's just time lost. Okay, you're not going to get a time back. Okay, and to see that person suffering is not easy, and certainly the person going through it is terrible. But it's not just pain. Sometimes in conditions such what we call acute delirium, when the person gets very confused, very agitated, that's also another kind of suffering, right? In fact, any kind of acute distress that is affecting the person or the family a lot, we should think about it as a kind of emergency. Okay, so palliative care is actually a lot of work. If by now you haven't realized, we do a lot of things. The scope of palliative care includes disease management, symptom management, psychological care, social care, spiritual care, practical care, and also we go past the point of death into bereavement care as well. So it's like we have to do everything everywhere and all at once. Okay, but of course this is not possible for any one person. So generally, palliative care, if you want to provide properly, should be done as a team. Now, palliative care is also urgent care because if you think about it, for anybody who has very advanced disease, we know that time is precious. And you can only make good use of this time when you feel much more at ease. So don't wait. Okay, if there's anything to remember, don't wait. Don't wait until the disease gets better, then you start doing things that matters to you. Don't wait, for the chemotherapy to work before you find ways to enjoy yourself and to find joy. Okay, sometimes we wait too long. We say, "Oh, wait until I get better, then I do." Wait until after the treatment regime, then I decide what I want to do with my life. But all this time, the time is passing, and sometimes you are not going to get it back. Another myth is this. So some people say cancer treatment means hope. Accepting palliative care means hopelessness or giving up. Unfortunately, sometimes the medical professionals give this kind of idea, because every time we tell a patient that there is hope, we always imply that there is treatment. And every time we tell them, oh, actually, when there's no treatment, we give the idea that there is no hope. But actually, that's not true. Even a person who doesn't have options for treatment, they are still alive. And when they are alive, they should be given the chance to live well. Okay, so sometimes people talk about hopelessness or giving up, and that makes it very difficult for them to accept palliative care. But what I want to say is, hoping for something unrealistic, or what we call false hope, only leads to disappointment. Okay, when we think about it, hope is something that helps us to move on, right? So if I say I hope to get to win the lottery, $1 million lottery, okay, but by hoping to win the lottery doesn't mean I get to win the lottery. But if my hope is alive to win the lottery, then I can say, okay, I can deal with my poverty right now. I can still find a way to live on each day, hoping that tomorrow maybe I win the lottery. Okay, so that's the idea. Similarly, hoping for that the disease will be cured is not necessarily wrong, but we must always be mindful. This is just a kind of hope. If we make it like it's an expectation, right? We want it to happen. So if you really want something that is very unrealistic to happen, then at the end, all you get will be disappointment, despair, and fear. Okay, every time the condition gets a bit worse, you feel a little bit more hopeless. Okay, so that actually promotes hopelessness. True hope, real hope, okay, if we take it in that sense, having a very, very down to earth, a grounded kind of hope, for example, hoping that, I will be comfortable, which is possible. Definitely palliative care can help that. Hoping that I won't have pain, hoping that I can still enjoy my time with the family. All these are actually very doable. Okay, and that can support us in finding a way to live on regardless of the illness. Okay, so sometimes what we tell people is, no, it's not wrong to have hope. Even if you hope for a miracle, it's fine. But do note that we should always hope for the best after being prepared for the worst. When we are prepared for the worst, we create a kind of safety net. Even if that hope for the best thing that you hope for doesn't come true, right? You will not fall, you will be supported. Now, how do we promote hopefulness? One way is to look at hope and break down this hope into, we can say, three components. To be hopeful, we must have first the capacity to realize the hope. So the more able we are to realize the hope, the more hopeful we can become, right? For example, if I hope to finish running a marathon and I'm not fit, then I cannot do it. But if I find myself getting fitter each day with training, then yes, my capacity to realize it becomes higher. I become more hopeful. The second aspect is this: I have a path. I know how to do it. Okay, to develop the path to realize it. And finally, what we hope to realize is important. So the goal, what goal do we hope for? And we find that palliative care helps in all these three areas. So the capacity to realize, palliative care helps by optimizing the physical, mental, psychological, and emotional state. The path to realize, palliative care talks about what needs to be done. Okay, not only that, it's not about what we want to do, but what needs to be done to reach our goal. It's also about what needs to stop. Sometimes, like I said, we busy ourselves with a lot of things, fighting over certain issues. But these things, they don't support the hope in any way. We can actually stop. Okay, and also very, very importantly, palliative care talks about who else can help. Sometimes we need to bring in other people, bring in other specialists, other professionals, but also we can also look at our own social setting and see who else can help. And finally, in terms of the hope to realize, palliative care always talks about what really matters. Go down to the essence, what really matters, and what is realizable. Now, this giving up thing is always a hot button issue, right? Because when people talk about giving up, it's always associated with notions of shame, of fear, of guilt. And that's why people don't want to give up. But I say something about giving up. Now, this idea of giving up, it doesn't really apply here, because we cannot give up what we don't have. If we are not in a state of health anymore, we can't say by agreeing to this kind of care or not agreeing, we get to retain our health. Okay, when we have come to a stage of a condition, it's not about giving up anymore. In fact, holding on to what is unreal only results in more struggling, more strife, more suffering, more despair. Right? What we sometimes should actually give up is that delusion. The delusion that we can or have control of everything. And my advice to everyone is, please, if there's one thing you shouldn't give up on, is never give up on care and love. Right? Care and love continues. Okay. Sometimes we confuse treatment and care. Right? And we sometimes think that giving up the treatment means we give up care and love. That's not true. Treatment, sometimes they are not appropriate. They give us more problems. They shorten our lives. We can give that up, right? But don't give up on care and love. So palliative care is therefore about life, right? It is a way to live well despite advanced disease. And how we do it is by reducing suffering from distressing symptoms, focusing on what matters to the person rather than what else can be done. In this internet age, there are so many things that you go to the internet and you find out what are the ways to treat a certain cancer. There are so many things that people say. Some are based on evidence. Many of them are based on just stories. And there's always something else that can be done. Okay, but is it what matters to that person? Okay, sometimes we have to ask the patient themselves, what really matters right now? Okay, encouraging a mindset to live a meaningful and quality of life regardless of circumstances. That is something that goes with palliative care. Okay, right now I'm just going to share a couple of stories with you about how some of the patients live with palliative care. One story that came up when I was preparing this talk was this the patient H. I'll call her patient H. This is a 62-year-old lady with very advanced uterine cancer that was diagnosed 3 years earlier. When I first saw her in the hospital, she had this abdominal swelling, she had leg swelling. The disease has also gone into the lungs, and then she has fluid in the lungs. So we help her to drain some of these fluids away so she can be more comfortable. But even as we are doing all this, and even before she was discharged, she was already planning what matters to her, what she wants to do. And she said, I'm going to plan to meet my friends. I'm going to have meals with them. I'm going to go out with them. So she was already focusing herself on what will bring her joy. Okay, and after discharge, in the subsequent months, we get updated about her food exploits. So she will go to a new place, and in her words, it's called 吃好料. So she will go eat something, and then they'll show us, send us the pictures about what she has eaten and so on. At one point of time when she was in the restaurant, the abdomen even perforated. That means the cancer has eaten through the abdominal wall and then resulted in a hole, and it started discharging all those foul-smelling things. She came back, we put a bag over it, and it was quite well sealed up. And even though the discharge was there, this bag, could easily be covered up by her clothes. And then she went back to her usual routine. And what we heard is that eventually she also went on a cruise and could even fly to Japan. So with palliative care, even without any treatment from that point of time onwards, this person actually maintained the quality of life, lived a very full life, enjoying herself. Another lady, I want to bring this patient up. This is about patient G. Yeah, it's because some people may say, look, this patient H has a lot of time in her hands. She's fairly physically well, so maybe she can do so much things. But here is an example of a patient whose disease is even more advanced, even much more aggressive, and she also find a way to make full use of her time, to live fully, even though her condition was bad. So this is a 70-year-old lady, again, also with very advanced uterine cancer, but her disease was diagnosed only 1 year earlier, and that tells us how aggressive it is. Basically, it spread to many parts of the body and even caused large masses, large lumps in the lungs and around the neck. And that's the reason why she's getting more and more breathless, because these masses are actually pressing onto the airway. And we managed to discharge her after some radiation and some medication. And to help with the breathlessness, she was started on morphine. Right? Morphine, many of you may not know, morphine is good for pain. Most people know that, but morphine is also useful for treating breathlessness. And with that morphine, she felt good enough to go out. And this is a picture, this is blurred out, of course. In this picture, she was walking in the beach with her family members. She said, I want to feel the sand in my feet. But actually, we know for her, what is important, what matters to her is the family. And she wants just to spend more and more time, as much time as possible with the family. And even when the breathlessness got a bit worse, we put a fentanyl patch for her. And that also gave her a little bit of relief, enough for her to go out for dinner and then go out for breakfast. Basically, this is a wish to spend as much time as possible with the family before the disease overtake her. Okay, I'm going to stop right here and maybe take some questions. So back to you, Mark.
Thank you, Dr. Tang, for your comprehensive and informative content. Indeed, early palliative care can improve the overall quality of life of advanced cancer. So I hope that everyone has also learned more about palliative care. So now let's take some questions from the floor. I see that Geraldine asked a question. So she asked, is palliative care affordable?
Yeah, well, that's a very good question. So palliative care, okay, let's put it this way. Palliative care can be obtained in different settings. So you can get it from most of the hospitals in Singapore right now. They either have a palliative care department or they even have a palliative care team. You can get it in the community hospitals. You can get it in the hospice, and hospice can be hospice team coming to the patient's house, what we call home hospice, or it can be inpatient hospice. Okay, there are also some centers that provide hospice day care. And right now, what I know is in the private setting, there are also many medical and nursing agencies who have staff that are trained in general palliative care. So certainly in the restructured hospital, there are government subsidies. and you can use MediSave. So palliative care definitely can be afforded. In the private setting, now private setting, certain insurance companies have riders, so you need to check with the insurance company whether there's a rider that also covers for palliative care. Okay, not all, I would say not all at the moment. Okay, hospices are usually run by charities. So hospices, home hospice, for example, as far as I can tell right now, they do not bill the patient or the family. Okay, so but the government supports them in the form of subventions, and they also raise funds for their own charity to fund this palliative care. Inpatient hospice, there are also government subsidies, and basically, in Singapore, if a person is really requiring a lot of financial support, MediFund will take care of most of the costs. So actually, anybody who has financial difficulties, speak to the social worker. They will probably link you up with a resource, and so that palliative care can be really affordable for anybody.
Okay, so for palliative care, there's a range of different prices out there. So there's the inpatient, there's also the hospitals, which also has the subsidies to help to make palliative care affordable. Okay, so any other questions from the floor? As we wait for more questions to come in, right, maybe I would like to ask Dr. Tan a question. Yeah, so Dr. Tan, how do we tell a loved one about palliative care?
Yeah, so this is always a difficult thing, isn't it? I think, like we were saying, just sometimes has to do with our ideas about what palliative care is, and we associate palliative care with like giving up and things like that. So first of all, recognize that it is not about giving up, because palliative care, how we tell palliative care to our loved one is that it's not that we are giving less care, right? But rather we are giving what is appropriate care right now. And the other thing that is important is that when we start palliative care, it doesn't mean things will come to an end, right? And palliative care, as a matter of principle, does not do anything that will hasten death, to make death come faster, or do anything that unnecessarily prolongs life. So it does neither of these. So what we can tell our loved one is that, at this stage, after going through all the treatments, you are still feeling unwell, you cannot function properly, you are not really able to live a life, then maybe we should find a care that is much more appropriate and addresses these issues. And most of our loved ones, especially when they have gone through a long illness journey, they know what their body is like. So they can feel they can sense, and they can feel what is going on with their body. So many of them actually hope a lot for comfort, not necessarily struggling on. In fact, just today I spoke to some patients, and both of them told me that what they hope is for the suffering to stop. Okay, so they are not so worried about that, and this comes from their mouth explicitly. They say no, they are not worried about dying or death. Okay, so never talk about palliative care as if it's something for dying people only, but you can tell them that this is something to help them live better.
So it's to let your loved ones know about the needs that they may be having, and to address them through palliative care.
Yes, correct.
Okay, so we'll wait for a while more for more of the questions to come in. But maybe I would like to ask a second question to Dr. Tan. So is palliative care slow euthanasia?
Yeah. So some people don't want palliative care because they think, oh, this is like slow euthanasia, right? It's killing the patient. Actually, we must be very clear about the distinction between euthanasia and palliative care. Euthanasia is when we prescribe a certain medication with the intention to kill the person. So like I said just now, palliative care, all palliative care interventions does not have the intention to kill the person. It is meant to alleviate the suffering, make people feel better, regardless of the stage of the illness. And there is a lot of research and data to show that giving such medications does not result in hastening the life, hastening the death, hastening the death. So no, it is not slow euthanasia. Now, most patients continue to deteriorate even while they're on palliative care, and this is almost entirely due to the disease itself progressing. Okay, so not to worry about this and euthanasia, not to confuse between the palliative care and euthanasia.
In fact, Dr. Tan, just now you mentioned about a research that shows that there's an regarding the like the expectancy of the life. There's in fact there's a increase in the expectancy when there is palliative care.
Yes, when there's palliative care added onto whatever they are doing. Okay. And the important thing to note is it's not about increasing the aggressive interventions, right? So it's not that, okay, I must qualify something here. So it's not you give up everything and then just take palliative care and then you will live longer. You can continue to try to manage the disease, to manage the cancer, but on top of it, add in the palliative care to address quality of life issues. And somehow people live longer. It is actually not difficult to understand. Now, when a person feels better, the body and the person and the state of mind, the state of body is in a better state to recover and heal, right? I think we generally know that. And palliative care can help with that.
Okay, so thank you, Dr. Tan, for the explanation. Any more questions we have from the floor? Okay, I would like to ask a third question, Dr. Tan. So, what do you do with someone who is fearful about dying?
So, I think when people are fearful, we also pick up the fear, right? We also get a little bit worried, and sometimes as a result, we try to reason with them, explain to them, and tell them to do particular actions as if those things by themselves will just stop the fear. But they don't work. These things don't work. I think it's important to recognize that people are fearful. Or maybe we think about it this way. When you are fearful as a child, long time ago, say during a thunderstorm, nowadays quite a few thunderstorms, how do you calm the child down? Do you scold the child and reason with the child, or this is a thunderstorm only, what is there to be afraid of? You don't, right? What do we do? Very often it's very simple, right? We basically hold the child, right? We hold the child, we say, talk to the child calmly, and then after a while the child settles down, and it's similar. So we have to hold the fear. That means we ourselves cannot be afraid. Okay, we have to hold the fear, provide a calm environment. Okay, don't criticize, don't judge them, don't explain, try to lecture them, and so on. Okay, and after a while, that closeness, that sense that somebody is there for them, will settle them down. Okay, now when we ask people, and as I said this earlier before, when we ask people what are they afraid of, many of them will say it's not death. They are not so much afraid of death, but they are afraid of what comes with the dying process and what comes at the end of life. So, for example, many patients will talk about their fear that at the end of life, they will have a lot of pain that cannot be addressed. Okay, so that's one aspect. Others will very commonly talk about, they are afraid that at the end they will lose control. That sense of control, they will get confused, they lose control, they shout, they get agitated, and so on. Now, so when we allow them to speak about all this, then we can find a way to deal with it. For example, what I can tell you about pain and cancer is that, first of all, not everybody will get pain. Actually, 25% of cancer patients will not die in pain. Okay, but of that 75%, the vast majority, actually, their pain can be controlled with whatever means we have right now. So actually, cancer pain, no cancer patient should die in pain with palliative care, right? With palliative care, almost any kind of pain can basically be managed. And very often, patients who are fearful of dying, once they hear that, then they say, okay, if you can tell me that I won't be in pain at the end, I will be okay, right? This is a very, very common response. But first, we need to find out what is troubling them about the dying process. And we can only find out from them if we ourselves become calm and calmly approach them without being judgmental and find out what really troubles them about end of life. Okay.
So it's to hold the space for discussion about death and be supportive environment.
Yeah,
And
absolutely
accommodate.
correct. Yeah, because you see, many patients try to talk about end of life, right? But every time they talk about it, everybody sort of tell them, don't think about this, think positively. And so where can the fear go? The fear is still inside. Nobody is addressing the fear at all. Okay. But when you think about it seriously, what is the dying process that can be so fearful? The dying process by itself might not be the most fearful thing. Things come to a stop. That's true. But it's actually all our different ideas. What happens as the thing comes to a stop? What happens after that? And things like that. Okay. These are not just imagination. We have to treat them as real stuff that disturb the patient. And we have to allow the patient to bring it up so that we can process with them, or at least let them know that we are there, we can hear them out, and they don't have to be so alone in their fear.
The acknowledgement is a very central role when it comes to discussion about death.
Yes.
And we have a couple more questions, stop the
Okay.
time. So Irene asked the question. So she asked, is caregiver support included in palliative care, and to what extent is it included?
A very good question. So palliative care, what is special about palliative care is that the unit of care is not just patient alone. It is patient and family. So caregiver support is part and parcel of palliative care, right? So caregiver support can come in the form of training, right? But it also can come in the form of emotional and psychological support. So that's why in the palliative care team, the three key members are doctors, nurses, and social worker. All right. Other bigger teams, they have psychologists, they have volunteers, they have counselors, and so on. And in some palliative care centers, they also have people like chaplains, so people who deal with the spiritual aspects of care and so on. So yes, the answer is yes, that's part and parcel of palliative care.
So palliative care involves a holistic approach from different.
Yes, definitely. Yeah.
Yeah, we have another question from Corinne. So Corinne asked about regarding advanced cancer, a patient with advanced cancer that is bedridden. So who can take care of such a patient in the day as well as the night?
Okay. So a lot depends on the care needs. Bedridden patients, sometimes they may have a lot of care needs, but some patients are just very quiet and general nursing care is all that's needed. If it's very straightforward general nursing care, then sometimes having a well-trained helper can be useful. And you may like to know that some of the hospices run caregiver training programs, and the helper can be enrolled in one of these, and then they can train. Now, if the patient is in the hospital, for example, and planning to go home, sometimes it's good to get the caregiver, whoever is assigned to be the caregiver, to learn from the in the ward first. Okay, uh, get well trained in the ward and then go home. Now, but of course, there are some patients whose needs are very high. Now, in that kind of situation, what can we do? So there are agencies, private agencies out there that can provide nurses, right? So, for example, patients with a lot of, who require a lot of medication to keep them comfortable, who has a wound that needs dressing and so on. So you can get a nurse. So nurses can do slots. So if it's like a very well-defined short kind of intervention, they can come into the house, do the dressing and all that, and then after that leave, or they come into the house for a say a shift, and then for the family members and caregivers to take a break. Okay, and then after that, when the family members have feel recharged, already have rested, then they can go back. So depending on your needs, so there are nursing agencies out there. There are those who can provide also nursing aids. So sometimes you don't need a full nurse. You can get a nursing aid that can provide most of the uh, address most of the issues like feeding, turning, dressing, toileting, and so on. So these basic things, the nursing aid sometimes may be good enough. Yeah. So so bedridden. Mm, but we really need to know how much care needs they have in the first place. Mm. I hope it answers your questions. Maybe if you can provide some details, we can go a little bit more into it.
Okay, so thank you, Dr. Tan, for the explanation. We move on to Lisa's question. So we break down according to sub-questions because she asked
Mm,
a couple of questions. So the first one would be, after government subsidy, what is the estimated cost of palliative care?
mm. So actually, it depends on. Uh, okay, so my assumption is we are looking at a situation where the person qualifies for government subsidies. So once they qualify for government subsidies, the degree of subsidies will depend on means testing. Okay, so it can be in some cases cashless. That means everything is covered. Even if there's a small amount that is not covered, a MediSave can be used. Okay, so that's the subsidized situation. For those that do not have not even have enough MediSave and things like that, uh, then MediFund can come in, and that will cover the cost almost totally. So the person doesn't have to worry about it. Yeah. So like I said, if there are financial concerns, it's good to catch up with the social worker and ask them to work out for the family what is um, the means testing result. Uh, I think generally it's about, if anybody has less than, I think something like 2008 per capita household income, that situation can get a lot of subsidies, almost like you don't have to pay any very much out of pocket.
Okay, so thank you, Dr. Tan. Yeah, so because of time constraints,
Mhm.
for the questions that are remaining, right, perhaps Dr. Tan will be able to answer after the session
Mhm.
via posting on the website.
Okay.
Yeah.
Yeah.
Mm. So thank you everyone for your questions, and thank you, Dr. Tan, for your sharing tonight and answering all of the questions from everyone here. So it's now time for Dr. Tan to take his leave. Once again, thank you very much for sharing your professional insight, Dr. Tan.
Okay. Thank you, everybody, for your attention and your questions.
So at this point, we would appreciate if you could complete the feedback form for tonight's session. Kindly scan the QR code on the screen with your mobile device or click on the URL link in the comments section to give us your feedback. Do follow us and check out our Facebook page for updates on our next 365 Live Health Talk at www.facebook.com/365CPS. Once again, do like and share our social media pages for the latest updates on our events, such as this Facebook Live event. Once again, thank you very much for joining us tonight. I hope to see you all in the next session. Take care, stay safe, and good night.